Everyone, thanks for coming out. My name is Steve Parente. I just want to thank Kyle and Mike for having me out here. Talk about the common sense approach to back pain. I'm a physical therapist, been practicing in Flemington since 1998, and I've been practicing as a physical therapist since for 26 years. So today, I want to just start it off. Someone in the office said you should really start it off with a quick story. And the story goes, I'm a year from graduating from PT school, and I'm doing an internship, and patient comes in with a script from the doctor that he has low back pain. Therapist, is teaching me how to handle this case. Back 25 years ago, it's hard to believe it's a quarter of a century ago, but 25 years ago, the basic prescription was like low back strain, heat, electric stim, stretching. He has a strain in his back. And so that's what we did. And so we laid the guy on the table, we put heat on his back, electricity, we shocked him with some electricity, and I think my instructor probably massaged his back a little bit, and he left. Second visit, he comes back, he feels no better. Third visit, we start stretching, so now the guy's laying on his back. You get your back muscles here. We're going to start stretching your lower back, and he's pulling his knees to his chest. Back then, it wasn't uncommon either to tell people, you know what, if it's really bad, don't be afraid to, stay in bed, bed rest. You might have heard that in the late 70s. A lot of people were told go on bed rest. So about visit 4 to visit 5, this guy comes back in, and he's crooked. The guy comes walking in, and I don't know if anyone's ever seen someone when their back is, when they're crooked, right? You see, and you're like, holy smokes. I'm sitting there, I'm like, at the time, I'm 21 years old. I'm looking at my instructor, I'm like, what the hell's wrong with this guy? What happened? He has a low back strain. He strained his muscle. And I could tell my instructor's like scratching his head. He's like, lay on the table. He gets out the electrodes, puts more heat on the guy, rubs his back more, sends him home. You know what? It's a spasm. Maybe we get you some muscle relaxers. And the guy's on muscle relaxers now. Next visit number 6, guy comes in. He's still crooked. Now the pain's like in his leg, outside of his hip. Guy comes walking in. He's like, guys, I don't know. This is killing. I haven't slept. It's down my leg. By the 8th visit, the pain was all the way down his leg. And by the 9th visit, he didn't come in. And we found out the guy had surgery. All right? So this is where, again, a quarter of a century ago, I'm sitting here going, what the hell is going on? Like, we get someone, what just happened? And my instructor looks at me, he's like, well, his nerve got inflamed and he had sciatica. I'm like, okay, and what's that? Like, he started off with a muscle strain, sciatica, surgery, weakness in his foot. So, I grew up on Staten Island. My mother's in healthcare. My father was a shop teacher. It's a weird combination, but I like helping people. And, I have a family full of engineers. You like to figure things out. So, I kind of, when I left PT school, I never forgot that patient because I felt like a technician treating this guy. I really had no idea what was wrong with the guy. Neither did my instructor. The books all told us, oh, if the doctor gives you a prescription that he has a strain because it's localized in his back, you put heat, electricity, you massage his muscle, give him stretches. And it wasn't a great feeling. I was like, we need to figure this out. So I graduated, went on my first job, and again, they were asking me to be a technician. I'm like, I can't do this. So I started a little place in Flemington in 1998. I was 25 years old, and I was learning how to figure this out. And that's when this whole kind of journey started for me, and it's going to go right into what we're going to talk about today, because it's a really common sense way of looking at compartmentalizing the different types of back pain. And I'm sure everyone here probably has pain. And so they're going to ask me questions, which is fine. Hopefully I can answer a lot of them during the talk. With that said, ProCare, which started in Flemington, we have 11 locations now. And to be honest, we're independent. Brian, Alyssa, Jared, we got some therapists here. I appreciate them coming. I didn't build ProCare, we did. And we're like-minded therapists. And we basically found 38 therapists in New Jersey that are thinking like we're thinking. Like, we don't want to be technicians. We want to figure things out. And if you could figure it out, I think somebody said Einstein spent 55 minutes to figure out a problem and 5 minutes to fix it, right? If you could figure it out, you could fix it. So that's what I want to talk to you tonight about. So much for this paper here. So, okay, common sense approach to back pain. If you drove from here to California, you could lump any musculoskeletal problem into 3 categories, okay? The first category is a tissue problem. A tissue problem is a sprain or a strain. A sprain is a ligament, a strain is a muscle, okay? So that's category number 1. That's usually localized. It doesn't spread down your leg. It usually happens in younger people, you know, like football players, they get sprains and strains. The next category is a structural problem. A structural problem is, I mean, the easiest example of a structural problem in the spine is you break your back. You know, your fractured vertebrae is a structural problem. Really bad arthritis, where you take an x-ray and you're just like, whoa, and you just see bone spurs and all sorts of structural deformities from age. That usually happens much later in life. All this stuff has variations, and don't hold me to anything. There's all variations, but nonetheless, structural problems is usually from a trauma or really, really elderly degenerative type changes. And I mean like 70 plus, okay? And then there's the third category, okay? And the third category is the one that I think most people know, but they don't understand. And we hear people come in and say things to me like, but if I take that medication, is it just going to mask the symptoms? Or how is it arthritis? I mean, I was fine until yesterday, and I picked up that paperclip, but I threw my back out, right? So the third category is mechanical back pain. That's the category that when the majority of people that we see in our office between the age of 35 and 65 are mechanical back pain. Now, it doesn't mean an 85-year-old can't have mechanical back pain. It certainly can, and we've certainly seen 25-year-olds have mechanical back pain. But again, I'm just going to lay this all out. And if we're going to play the odds, I think the majority of the people here probably would fall in a mechanical back pain. So I want to talk about mechanical back pain. And what is mechanical back pain? It's, like I said, I threw my back out, right? That's the person. Mechanical back pain is when your spine isn't working right for whatever reason. We're going to get into the number one reason why it would not work right. And I use the analogy all the time in the clinic of a door hinge, right? When I was a kid, my brother and I we grew up in a small house, and we would play football in the hallway upstairs. And he'd tackle me, and I'd bang into the doors. My dad would come home and start screaming at us. And one time, we banged into the door so hard, the door didn't shut right, okay? And so my dad comes home, he's like, screaming at us, and he goes over, and he was a shop teacher, so he's like, get my toolbox, and he's like, oh, sorry, Dad. And he grabs the door, and he puts his foot on one side. He goes to shut the door. It's not shutting right. He puts his foot on one side of the door. He pulls the top of the door like 10 times. He goes to shut the door. It's worse. So what does he do? He puts his foot on the other side of the door, pulls the door the other way 10 times. Door shuts. And he's like, stop playing football in the house. He fixed the door. And so that's a great example of a mechanical problem. If you took an X-ray or an MRI of the hinge, you really wouldn't see anything. If you put WD-40 on the hinge, like an injection, or you gave it pills, it's not going to change it. He had to make physical change to the hinge. And so that is the majority of patients we see are mechanical back pain. And I'll tell you why, because most muscle strains, they get better on their own. I mean, I don't know. I strained my back when I was younger, digging a hole, and I take some Advil, it goes away, okay? Localized back pain, it doesn't tell you anything. It could be a strain, or it could be the start of a mechanical problem. And the guy that came into that office when I was in 1994, they said he was a muscle strain. They said he was a tissue problem. We treated him like a tissue problem. And then all of a sudden his spine shifted, the pain hit a nerve, it started to go down his leg, and he had a mechanical problem that really went untreated, and then all hell broke loose for that guy. So let's real quick talk about the number one mechanical problem in the spine. Let's just go over real quick anatomy, all right? Here's a person here. facing this way. And our spine, we have these stacking blocks. They're called vertebrae. Right? They're like black blocks when you were a kid. You know, they stack right on top of each other. There's 7 of them in the neck, 12 in the thoracic spine, and 5 in the lumbar spine. In between, you know, I'm going to get down to the lumbar because that's an easy one to give an example of. In between every one of those vertebrae, you know, in the spine, you never have bone on bone. Well, you don't want it. You don't want bone on bone anywhere in the body. You have a cushion there, and the cushion, we all know the cushions. I think a lot of us know that's the disc. It makes for a good shock absorber, okay? The disc has a jelly in the center, and yeah, that jelly is more plump when you're younger, and it's a little drier when you're older. But nonetheless, that's the makeup of a disc. So what we see a lot of with mechanical back pain is, I mean, if you bend forward all day long, or if you sat all day long, and your spine is constantly being flexed, right? This is, you know, it's constantly being flexed. What happens at the disc, okay? The vertebrae come together over and over, or sustained, sitting, squeezing the front of the disc, bending, squeezing the front of the disc. You put pressure on the front of the disc. What do we see? We see movement in the disc. The most common direction the disc moves, it starts to move backward. And that just makes sense. If I told you to go over there in the corner and bend forward 5,000 times, you'd look at me and be like, Steve, I don't know if I want to do that. By 5,000, you'd probably walk out of here like this. Why? Because you can actually take the jelly, squeeze the front of your donut so many times, the disc shifts backward, and now you're walking like this. Unlike the guy who was like this, right? Some people get out of their car, right, and they get up and they're like, ah, okay? That's movement of the jelly. The movement of the jelly, there's a normal amount of movement in that jelly. If you bend forward, the jelly shifts a little bit backward. If you bend backward, the jelly shifts a little bit forward, side to side, right? When you get out of the car, Kyle's driving the kids to Disney World. He stops on 95. He gets out of the car. First thing he does, hands on his back, bends backward 10 times. He just instinctually does that. So this right here is a really basic explanation of mechanical back pain. It changes rapidly, mechanical back pain. There's rapid change to it. You throw your back out. You know, you could throw it out, but you could throw it in. And so that's what we do in therapy. We try and fix it. Now, if you took this disc and you took it out of your body and threw it on a table and then cut the top off the disc and lifted it and looked at it, right, like from an aerial view, you would basically see the jelly in the center. Remember, you're looking, we'd lay this thing down, but you're looking at the top down. And in this case here, bending forward, you put pressure on the front of the disc, right? That's that flexion motion. And the jelly would end up over here. And now the crust of the disc, they're like rings of a tree. The jelly starts to push and it starts to bubble out, right? And people know, oh, it's a herniated disc. It's a slip disc. Yeah, that's the most common herniated disc right there, okay? But you can also throw a disc out over here. It could go on a little bit of an angle. Or it could go out to the side. Remember that guy who was like this? It went out to the side. It's a little controversial, but some people believe that this could actually go forward in rare cases, like gymnasts and whatnot. And so, you know, knowing this, when people come in, you know, a therapist is going to ask you a bunch of questions, and they're going to try and figure out, is this a simple strain, a tissue problem, or is this a mechanical problem? Now, if it's a mechanical problem, the first thing that happens is when that jelly starts to come back into that donut is you feel back pain. The second thing that happens is the further it comes out, it starts to radiate. And there's a nerve right here, right? There's a nerve right here. And then this is your leg right here, and that nerve. And if that jelly comes out a little too far, it dings that nerve. And the further out the disc comes and the harder it hits the nerve, the further down the leg the symptoms will travel. So if you're a therapist, you know this, and you know that if it's all the way down your leg to your foot, you start saying to yourself, wow, it's hitting the nerve pretty damn hard. If it's in your hip, you're like, oh, it's hitting the nerve 25%. If it's to the knee, it's hitting the nerve, squeezing the nerve 50%. And if it's all the way to your toes, it's compressing the nerve pretty hard. Now, with that said, if you have a patient come in and they say, yeah, my foot's bothering me and it's down my leg. I have sciatica. By the way, sciatica is just a nickname for the nerve being pinched, right? Remember that guy said to me, oh, sciatica. It wasn't sciatica. That's just a nickname for a mechanical problem, the result of a mechanical problem. But a therapist, if they start treating you the right way, they're looking to get the symptoms to travel back up the leg. So if the disc comes out, hits the nerve, it's harder to squeeze it, further down it goes. We try and reverse that process. Bring the disc in, take pressure off the nerve. That's called the centralization phenomenon. Sounds like I just made that up. That's actually what they call it. And that is really the barometer for treating sciatica. If you're doing something and it's going down your leg, stop doing it. And ask yourself, what am I doing? Because whatever you're doing, usually the opposite will probably fix you. You remember my dad pulling on the door? He did the opposite movement to fix the door. And so that's the definition of mechanical back pain. There's rapid change. It refers symptoms, the worse it gets. Usually the one direction, it has a directional preference. One direction is going to make you worse, where the other direction, usually the opposite, will make you better. And depending on where the disc is, the therapist needs to figure this out and figure out what movements, and they'll push on you and twist you and lean on you and have you do exercises to push it in. And this essentially right here, between the age of 35 and 65, makes up about 82% of our back pain in our clinic. It's a tremendous amount. Now, I mentioned squirting the WD-40 on the hinge, and I mentioned an MRI. Look, medicine really addresses, typical medicine addresses structural problems very well. I'm not so sure it addresses mechanical problems all that well. I mean, if anyone here has been to a doctor for back pain and they don't even move you, how could you assess a motion problem if they don't even move, a mechanical problem if they don't move you? How do I know if the door is not working right if I don't shut the door? So we do tend to, in medicine nowadays, we do tend to get caught up with still pictures. Still pictures are great. They show structure, but they don't show mechanics. And I'm not killing medicine. I mean, we're in medicine. We work with doctors all the time. But that's a piece of medicine that, hey, if we could do a motion MRI, I think it would tell us a lot more. But we don't. We take a still picture. So still pictures show structure. Oh, it's not broken. Oh, you have a bone spur here. Oh, it's this, it's that. If you took 100 people that are normal with no back pain and took an MRI of them and an X-ray, it's some crazy statistic, like 78% of them will have pathology and they don't have any pain. So it starts to get a little unreliable, these still pictures, right? So to put someone through movement testing and symptom response testing is what we do in physical therapy. And to me, that's just common sense. So if I said, Kyle, your back hurt? He says, yeah. He's bend forward 10 times. Bend forward 10 times. Squeeze the front of the disc 10 times. Well, just bend forward. I don't care what it is. I don't care if I'm changing the pH of your blood. And you say, Steve, my back pain went from a 2 to a 10. And I say, oh, okay. Bend backward 10 times. How's it feel now? You're like, yeah, it's back down to a 2. I'm like, keep going. You're like, it's a 0. Okay, good. I just fixed you. I know that sounds ridiculous, and it's never that simple. But that is essentially what I wanted to talk about today. And when I joined this gym, I noticed right away that I don't do these talks. I really don't. I talk to patients in rooms. But when I joined this gym, the one thing I noticed that they did was we spent the whole first 10 minutes stretching. And every time we stretch forward, the next thing would be stretch backward. If we stretch to the right, we stretch to the left. It was always, and then we started doing exercises. Every time we did a pull strengthening exercise, we did a push strengthening exercise. And I'm sitting here going, my back's feeling pretty good. Like, I feel good. And I have back pain too, And so the reality of it is a healthy spine should be able to move in all directions. And what do we do all day? We sit all day. We bend all day. I mean, how many people bend backward, right? How many people lay on their stomach and extend their spine? Not that many. And so, I was a kid. I used to watch TV. I laid on my stomach all the time. I watch TV like this. And we don't do that as adults. And because we're always bending and sitting and slouching and bending and bending and bending and never bending backward, it's kind of like saying to Kyle, stand over there, bend forward 5,000 times. We're all doing that all day long. And that's the result of it. So I'm glad to open it up for questions. I know I didn't cover every problem that exists on the world in the world, but I will tell you that the majority of people between the age of 35 and 65 have mechanical back pain, a large majority, and the disc is the number one reason for that. Any questions? Before I open a question, there's one other thing I just want to mention. The number one exercise we prescribe people is lay on your stomach and bend backward. Number one. There's a reason why every car in America is built with a lumbar support, because it wants your spine extended, arched, right? It's like you have an arch support in your shoes. Why don't we have an arch support in our car? Well, we do now. I mean, most cars do. Any car, I think, over $15,000 probably has some lumbar support in it. It's because we want to get out of this flexed position. And this flexed position is squeezing these jelly donuts and squeezing it out. So when we talk about treating back pain, common sense says, be balanced. If you sit a lot, well, then walk a lot. Offset it. They did a study years ago before all these fancy equipment. They had a guy walking on a treadmill, and they put an x-ray machine next to him, and they took like a zillion x-rays of him all at once. And they stacked all the films, back when they had films. And they literally made a motion picture out of the x-ray. And they flipped through it. And what they saw is when someone walks, your pelvis just kind of flips, and your back goes into these little extensions, little extensions. So people that have back pain, they're like, yeah, I feel, they're coming. I mean, it's like, if you guys were a fly on the wall in our office, it's like, you do hear the same stuff. It's like, it's killing me when I sit. How about walking? Well, it's tough to get up. But once I'm up and I start walking, I feel a lot better. And you're like, right? So these are like things we hear all the time. I see people shaking their head because I could guarantee you probably are thinking like, yeah, I love taking a dog for a walk. It makes my back feel good, right? So the common sense approach to back pain is check yourself. Maintain good range of motion in all directions. If you're limited in one direction, go move in that direction and make it looser. And maintain healthy range of motion throughout your spine. If you do, you'll maintain good balance, right? And if you press the front of the disc 10 times, the back of the disc 10 times, the right side, the left side, all 10 times, I'm pretty sure that damn thing's going to stay in the center. And so when we overload one direction, we run into problems. Now I could answer questions. Fire away. I'm happy to answer any question about anything, not even just about this. Go ahead, Kyle. Yeah.
If the hip flexors are tight, and maybe some people that don't know what they are, explain that
Yep.
in a second. But if they're tight, can that contribute to the mechanical pain?
Mm-hmm.
All right. So I guess answer that one first.
Okay. So your hip flexors are your muscles in the front of your hips. So why would they be tight? Well, we sit all day. You shorten them, right? So when you spend time in this position, these muscles do tend to get tight. So it's funny because the number one exercise we give people is lay on your stomach and bend backward. It stretches your hip flexors. But I'll say this, because there's a belief out there like the psoas is tight and that's what's causing it. If a patient walks in with back pain, and I tell them, I'll use this as an example. I'm bend forward, they bend forward. I go bend backward, they're like, oh. I'm like, where's it hurt? Right back here. It's not their hip flexors, right? There's something here. I'm like, could it really be a muscle thing? I mean, I'm asking you to slack all your back muscles, right? You understand slacking things, right? But when I go backward, I put my muscles in my back on slack. So what's stopping me from going backward? Especially, now look, if you said, oh, it's stopping me here. Oh, your hip flexors are tight. But that never happens. It rarely happens. I mean, it does. I'm not saying that doesn't exist. But if you bend backward and you're not going real far and you hurt back there, you're obstructed, okay? So the obstructed movement is most likely that. The psoas and the hip flexors, that's a great conversation because there is stuff going on with that. But that's like a secondary result of a lot of this stuff. And so a lot of people believe if you loosen up these psoas, it's going to help. And it does, because you could go further and you could really reduce this. But nonetheless, the hip flexors, you do see them tight. The stretches to fix this kind of addresses that indirectly. It's not something we wouldn't look at. But more often than not, if I see an obstructed movement, it's blockage. I got to clear that blockage. And you know that because you have restricted motion and where the pain is. If it's back here, slacken the muscle. It's got to be something on the spine, right? So I don't know. Hopefully that answers your question. What else you got? Go ahead.
What will be your top 3 exercises to address the north, south, east, west of that lower?
That's a good question.
That you're not going nuts lifting
Yep.
deadlifts or anything like that. Just something that's going to target
Yeah.
and keep it limber.
All right. You're going to see I'm biased here. It's obviously not going to be flexion, knees to chest, right? Remember that guy that came in 1995 cranking his knees to his chest? That's the last one, all right? The number one exercise I would do for the lumbar spine is lay on your stomach and bend backward. The number one exercise I do for my cervical spine would be tuck my chin in and extend it backward. The number one exercise I do for my mid-back would be lock my hands behind my neck, use the back of the chair, and extend backward. You can see I'm biased to extension. Because what do we do when we sit? We sit flexed, our lumbar spine is flexed, our thoracic spine is flexed, my head is protruded. So what did I just do? I did the opposite. I want to retract the cervical, extend it, extend the thoracic spine, and extend the lumbar spine. Now, that's for the whole spine. As far as the other exercises go, rotation, side bend, it's not rocket science. You put on any, workout video and just, it's basic. There's only so many ways the spine moves. So yeah, to go right rotation, left side bend, right side bending, extension. The one that we tend to steer clear of a little bit is flexion, because we do so much of it during the day. It's funny. We had a patient not too long ago comes in and they're like, "Yeah, my neighbor told me my core is weak." I'm like, "Oh, okay. So how's it going?" They're like, "Well, I was having back pain, so my neighbor said start doing like crunches, like strengthen my core." So then what happened? They're like, "Well, I went into my hip, so I doubled down on the crunches, and next it started going down in the leg." And I'm like, we got to stop doing the crunches. They were just repeated flexion. They were, to get strong abs are good, but to get strong abs to the point where you're squeezing the disc out is bad. So get your disc in, keep it in, and then let's build some strength around your spine and the front of your spine, the back of your spine, the flexibility, like we said, the equal range of motion. That's what we want to do. So, yeah, hopefully I answered that.
Very good. Thank you.
Yeah. Go ahead. Yeah, sure.
Yeah, so you kind of answered one of the questions I had, which was the cervical part.
Yep.
Right? So you can kind of do the same types of things.
Yep.
Right, 'cause it's all connected, right? I'm actually coming back to ProCare on Monday because I re-injured doing some exercises and stuff. I re-injured my neck and my shoulder, and the orthopedic said, your real issue is your neck, not your shoulder.
Yeah.
It's
I'm glad you said something about that. Yeah.
Yeah, so can you comment on how that's related? I didn't really get
Yeah.
into it with them. And number 2, is the shoulder normally mechanical too, or is it I'm just trying to figure out how
Yeah.
to
As far as remember I said we could drive from here to California, stop at every orthopedist. Those 3 buckets apply to every musculoskeletal injury in our body. I could give you mechanical problems in a knee. Kyle knows. Shoulders, there's mechanical problems in everything, right? Kneecap problems, shoulder impingement. There's a number of mechanical problems in every joint. We're just talking about the spine tonight. Now, with that said, 82% of all, there was a study recently done in Canada, 82% of all hip pain is actually the back problem. And I feel bad for the guy who got a hip replacement because they x-rayed his hip and like, oh, it's obviously your hip, it's arthritic. And the guy goes, it's a hip replacement. And he's like, my hip still hurts. And we lay him on a table, we do a few things, and we reduce his back problem. And then you're like, yikes, we just did that. Now, that doesn't happen all the time. And to be honest, I don't even blame the surgeon. The guy had a bad hip. He changed it. But nonetheless, that wasn't his problem that day. The problem was he had a hip problem. That's of the hip. Of the shoulder, it's not as many. It's like 24% of shoulder problems are related to the lower cervical spine. So I'm glad you mentioned that. So sciatica is the pinched nerve in the lower back. That goes down your leg. The nerves in your lower back travel down your legs. The nerves in your neck travel, the lower neck travel down your arms. So it's the same rule, the centralization, right, rule. The nerves in your upper neck travel into your head. We see a ton of headaches in our office. Because when they're loaded up on like migraine pills and they've been through all these treatments and like nothing's working, or they come off the pills, they come in, we fiddle around with their upper neck and their headaches go away. And they're like, how'd that happen so fast? We're like, it's rapid change, right? We figured out the direction to take pressure off the nerve and it got rid of their headache immediately. If we could do that in the office, we know you don't have a migraine. I can't fix a migraine. That's in your brain. That's out of my jurisdiction, right? So to answer your question, yeah, I mean, shoulders, neck, hips, back. We had a therapist in our office, Eric, he's not here tonight. Guy's long, lean, he's a runner, guy's in great shape, comes in, he's complaining his Achilles bothering him. So we're sitting there doing Achilles exercises, like we're just trying to help the guy. He wants to run a triathlon. This is years ago. He calls us up the next day, he's like, I can't come in. We're like, what happened? He's like, my back is killing me. We're like, holy crap, we missed it. Like, we thought he had an Achilles problem, and it was really a back problem. And it's funny because he didn't have any back pain. He didn't have that line, that sciatic line. He just had Achilles pain. When his back went, then the line appeared and it showed up. And it's weird like that. The nerves get a little weird. Sometimes it jumps, And so I'm glad you mentioned it because it could get very confusing. It could get very, very confusing. And you could swear. He swore. This guy's a therapist. This guy's been doing great therapist too. He's been doing it for years. He swore he had Achilles tendonitis. And so I don't blame you for getting fooled, but it is true. It's a very good chance it's all neck related, your shoulder.
Yeah, they call it deferred pain, I guess.
Referred pain, you have radicular pain, pain that travels along the path of a nerve. It gets very confusing.
Yeah, thanks for that explanation.
Yeah, no problem.
I'm trying to figure out how it all works.
Just sit up a little straighter, though. I'm just kidding. I'm just saying.
I couldn't wait till Monday, I guess. I'll start now.
What do you got?
Roll out on your back and you just hear pop.
Yeah, right, sure.
What's going on when you're back?
Yeah, it feels good. It's no different than like cracking your knuckles. Like I didn't get into the joints of the spine. In the spine, every one of these vertebrae has two little knuckles that are on each side, and it protects there's a joint and there's synovial fluid, and so it's like cracking your knuckle. So you're cracking those joints. So that's kind of like what that is. Feels good though. Yeah, go ahead. Do you have a question? No. Yeah, go ahead.
So I'm just wondering, the shoulder pain and, your neck issues, whatever they are, are those related to like carpal tunnel or the ulnar nerve thing?
Interesting, yeah. Yeah, so, again, if you were a fly on the wall, right, people come in, they're like, yeah, I got pain here in my pinky, and the first thing we do is we go right to the top of the chain. And we said, let's check the neck. Sit right here, and you sit there. And the therapist does their thing. They start moving you around, move this way 10 times, move this way 10 times. We take them through a system. There's an algorithm of movements that we take you through. And then I'll say to you, how's the pinky now? And you're like, it was a 2 out of 10. Now it's a 3 out of 10. Oh, okay, keep moving. So I'm sitting there going, she don't have carpal tunnel. Like, you know what I mean? I can't make carpal tunnel worse by moving your neck, And so... But there are times we move the neck and there's nothing happens, and then you do have carpal tunnel, and so that's a whole other issue. But this is my point about, I talk about our therapists, and this is like a never-ending journey for us. Like, we're not technicians; we're going to figure it out. I always say, like, there's someone out there that can figure it out. That's what we kind of pride ourselves on. Just we got to figure it out. And if we figure it out, we know what to treat you with. We might do a gazillion movements and figure out that you have carpal tunnel. Then we start looking at your carpal tunnel, and then after the third visit, we're like, look, you need carpal tunnel surgery. And you might have to have carpal tunnel surgery. We could talk about surgeries in a minute. Mike's going to throw some things at me. But that's a great question. It all kind of comes in line like the shoulder, the carpal tunnel, the ulnar nerve. It's all there related to the nerve. Yeah, go ahead, Nancy.
So Steve, I've had decades of pain.
I do.
For a very long time. Mechanical, but recently I was diagnosed. You were suspicious of it, but then the doctor diagnosed fibromyalgia.
Yep.
About 3 weeks ago, I had an anxiety attack.
Mm-hmm.
Very bad. And the pain in my back was the worst. I
Yeah.
just dropped out of
Yeah.
the second story.
Yeah, absolutely.
But I did the exercises that
Mm-hmm.
Brian gave me.
Yep. Feel better. Yeah.
I was fine within hours. Now, is fibromyalgia similar
Yeah.
to IBS in that it's a misinterpretation
Yeah.
of the pain?
It's a good question, Nancy. Like, so remember I said there's 3 buckets, right? So if you have fibromyalgia, it's a problem it's a tissue problem, essentially, okay? And so I didn't want to get too deep into this, but a lot of these 3 buckets, sometimes they kind of overlap a little bit, right? So, you could have, we've seen people with neck problems start to develop tendonitis in their shoulder because things are just so screwy and whatnot. So I would say fibromyalgia is more into a tissue problem, but you have, I don't want to sit here and violate HIPAA, but you have a long-standing history, but you fall into this. So we have a good grasp on how to treat it, and especially knowing your history. But no, thanks for the question. Go ahead. What else? Fire away. Give me more. Give me more. Anyone else? Go ahead.
Well, I'm beyond the age group that you.
Yep.
I'm 79.
Yeah.
Possibly.
Yeah. Sure.
A lot of spinal stenosis.
Yep.
I've lost 3 3/4 inches vertically.
Mhm.
And I've had 2 laminectomies.
Yeah.
No gain. I get the numbness, goes down here, and then it will continue to travel down to my foot if I don't sit down.
Yep.
Trouble standing up. I mean, I can't stand. I couldn't.
Right. So you see, you're the opposite of the mechanical guy. You're more the structural guy, right? Are they talking about doing a fusion? Have they talked to you about that?
I have a possibility of that, but most of them don't want to go in. They take a look at the MRIs and they
Yeah.
see how bad it is.
Yep. I get it. Yeah.
They
Sure.
don't want to touch me.
Yeah.
So I'm just looking for anything.
Yeah, so, in the case of, in your type of case, the only reason why I would have surgery in your case, if you started to have weakness, if you started to get foot drop or fall down, then you need surgery, okay? And they'll do it. You find the right neurosurgeon, they'll do it. Call us. We'll tell you, a list of doctors that would do
Nobody
it.
around here, but I did.
Yeah.
I found
Yeah.
one in Wyoming and one in.
Now, if you don't have weakness, well then, again, you want to maintain what you do have. You want to slow the progression. So again, to take your spine through range of motion, it's okay, to stretch the nerve so it doesn't kind of get bound up in there, to do like hamstring and nerve glide stretches. And we teach people that. But you're right, it's a structural thing. You have to maintain it. And it's kind of like a diet, If you stop doing it, it's going to get worse.
I do notice that the more active I am, the better.
The better you are, yeah.
And I do a lot of bike ride. I'm a snowbird, so I go to Florida.
Good.
And I'm 8-10 miles.
Great.
3 days a week, 4 days, whatever.
Yeah.
I don't have a problem. I have places I can stop and sit down if my leg goes numb, and
Yeah.
I just get back. Like within a minute or 2, I get the feeling back,
Yeah.
and I get going.
The thing,
I do remember.
Yeah,
We
go
talked
ahead.
about that one exercise, laying on your stomach.
Yep.
I do remember that in the early days when I was first having back,
Yep.
that was one of the exercises, and I haven't really gone back to that. And I'm thinking, the more I'm listening,
yeah.
that maybe. I mean, I have a lot of stenosis, so there's a lot of stuff.
Yeah, so you don't want to bang on that, but you know what? Lay on your stomach. Just lay on your stomach. Don't even do anything. Just lay on your stomach. I look at people and I go, "I'll lay on your stomach." And they look at me. I'm like, "What's wrong with your stomach?" They're like, "I haven't laid on my stomach in 10 years." And I'm like, that might be the problem, So, and again, I know it's not comfortable, but okay, laying on your stomach isn't going to kill you. You're not going to be in surgery because you laid on your stomach. Let's give it a shot, And so that may be a start, Don't start banging on it. Start on your stomach and then up on your elbows and then progress from there. See how it goes. Yeah.
So, like 7 years ago, I had C4 and C5 fused,
Yep.
and now, like the past 3-4 months, I've been getting
How many years ago?
about 7 years.
Oh my God. I got to tell you, I swear they install a ticking time bomb into these fusions. And I'm not knocking fusions. People need fusions. Isn't it always 7 years? I feel like at 7 years, people start to have problems with these fusions. So go ahead. I want to hear about it.
So it was about 7 years ago, and now all of a sudden, in the past 3-4 months, I've been
Yeah.
starting. So I went to the doctor, MRI, X-ray, blah, blah, and they're saying, and if they would have told me this before they did the fusion, I
Yeah.
probably wouldn't have done it.
Yeah.
But you're saying now, because of the fusion, the discs above and below
Yeah, absolutely.
are starting to compress because that has to bear the weight of.
So yeah, you have 7 vertebrae here, right? So what they did with you is they took, this 1, 2, 3, 4. Which one was your level?
4, 5.
4, 4, 5. Right? Here's your disc right here. So the surgeon went in, they put some metal in there probably, right? So put a piece of screw and a plate, and they just took the disc out. And they put a plate and a screw. And so now and then they put some bone in there, and now you have one vertebrae, right? They made one.
Right.
So, but the problem with that is there's a lot of good that comes in a fusion. I mean, they remove an entire motion segment, and it instantly relieves the choke nerve instantly. I mean, you wake up from surgery, and you're like, holy cow, I'm better. The problem is you have 7 vertebrae in your neck, and they all move like, I mean, I'll just say this, it's not necessarily true, but 1/1/7. And so now you're missing a motion segment. So now the one above it, the disc above it, is doing more, and the disc below it's doing more. Now you might just have a mechanical problem above or below it, and we might be able to help you. Or they might say, hey, let's fuse another level. It's like a cascading problem where, now all of a sudden it's like fusion. We've seen people with, over years have multiple fusion surgeries every 7 years. But I'm not here to try and wrangle up patients. I'm just trying to educate people. And you look familiar. Yeah, Eric, yeah. He's the guy with the Achilles. But yeah, so that's your problem. I mean, that makes sense, right? Common sense. I mean, if you eliminate one of the motion segments, you're going to have a problem eventually. I swear it's always 7 years too. Maybe that's just me. Go ahead. What else you got?
I know I look young, but I've been told one of my discs in my neck is degenerative.
Yep.
So I'm gonna guess that's irreversible. But is there anything that
I'm so glad you asked that question.
strengthen that? Or
Yeah.
prevent it from getting worse?
Yeah, I'm so glad.
Because I'm the generation of TV.
Yeah, I'm really glad you asked that question. So they took a still picture of your neck, and they were like, oh, you got degeneration. How old are you?
36.
36, yeah. So, what is that? I know what they saw. And basically what they saw is like a narrowing. So, the X-ray, you have a vertebrae, and then you have a vertebrae, and remember I said you got this disc here, and you have this nice plump jelly. And you got like let's call it, I don't know, a 1-inch space. A degenerative disc is, now you have a vertebrae, and then you get a little disc, and it's this big, and they go, oh, look how narrow that is, right? They're closer together. Is that what they saw? Yep. Yeah. So, what is that at 36? I got to tell you, I mean, you might have that, and you do have it. I mean, it's not lying. I mean, you see it on the picture. Maybe that's not your problem. Maybe we could do something about it. Or, when I talk about this disc, a lot of times the people that have these disc problems, let me draw a better picture. I'll take this one here. Remember I said, this thing's a nice little tight little bundle, right? That little jelly. And sometimes when it starts to push out, it disperses. So instead of your jelly donut being a nice kind of round ball, now you have it kind of just, it's like a flattened whoopee cushion, It's like kind of just like and so what's going to happen then? You don't have this nice little ball holding everything up. So everything starts to come down. So in your case, you say, well, is that permanent? So the outer 2/3 of the disc, remember I said there's like rings, there's like these flaky like tissue rings. That's the crust of the donut. The outer 2/3 of that crust, the outer 2/3 has blood. So you could wrangle up some of that jelly and be real, and try and do everything you can to get it all kind of stuffed back in there and be real good about posture and stop slumping on your phone and it starts to heal. It's not easy, but we have patients like this, and people do get better. Now look, if it's so narrow and you can't get it all in, it's going to start to narrow, and you start crushing nerves, and so it's complicated. But yeah, that is definitely something we see often in our office, very often.
The therapist at the time said he was seeing it more and more.
Yeah,
People my age.
yeah, definitely. And you got to know what you're doing to kind of get that stuff wrangled up. Years ago, I was like, I hadn't bent forward 10 times, I've been backward 10 times. I'm like, that's great when you're healthy. But when you're not healthy and you're trying to fix a mechanical problem, that doesn't work. If my dad would have pulled the door one way and then the other, The door still wouldn't have fixed, right? He picked one direction. So you got to really, you got to figure that out. Yours is like a puzzle that would need to be figured, if it could be figured out. Is this making sense? Is it making sense? Okay. I'm happy to answer any question. Go ahead.
Can you talk about anterior pelvic tilts?
An anterior pelvic tilt. So an anterior pelvic tilt is just a position of your pelvis. Is there a problem with that?
Kind of hurts my back.
It hurts your back. Interesting. So we try and teach people to perform an anterior pelvic tilt. What an anterior pelvic tilt is, here's my pelvis. It's like a bowling ball. And I'm trying to get people to tilt their back to create that arch. Because the majority of people, remember I said that jelly, you squeeze the front. Some people, in a rare instance, remember I said there's a few people that have other things that go on here? Some people, their problem isn't too much flexion and slouching. Their problem is too much arching. And so when you have a problem with too much arching, now you start to develop a different kind of problem. So I don't know, I'm not going to tell you what's wrong with you or what to do, but knowing that, if your problem is an anterior pelvic tilt and you're so arched, would I tell you to lay in your stomach and do backward bends? Probably not. You might actually do knees to chest. Makes sense, right? It's common sense. If you want to talk to me more about that, but that's really, we're always trying to get people with these lumbar supports to be in an anterior pelvic tilt. Yeah. But some people have too much of one. You're either a dancer or you ride horses or? No?
But from when I was little, like I always had like an
big time
in my
arch.
back. Every time I lay down, like there was this much space.
Do you get radiating pain ever down your legs?
Sometimes.
Does it ever go below your knee?
No.
You should come in.
Yeah. I mean, I'm
You should come in.
for an elbow, but it's probably
Yeah, you should talk to the therapist. There's like 2% of the population that develop a weird problem. It's not anything bad. I mean, we just gotta. But what happens to those people is they get thrown into like the basic, like, oh, lay in your stomach and do backward bends, And it's like everyone's doing backward bends. And it's like, and you're getting killed, right? And so we might be able to figure that out pretty quickly, actually. Yeah, go ahead, Joe.
What is the difference between a chiropractor and a
Oh,
physical therapist?
I knew that was coming. Joe, it had to be you, Joe. You're a paisan. You're a paisan. So I got to tell you, chiropractors do mechanical treatment. The old school Palmer trained chiropractors, they do mechanical treatment. So we're not anti-chiropractors. We're really not. Chiropractors have evolved. Like physical therapists went from being technicians to being, doing the stuff we're doing now. We're figuring things out and coming up with the solution. Chiropractors were very much treating people, and they've gotten a little less aggressive over the years. And I'm not saying anything negative about chiropractors. I think everyone knows when you go to a chiropractor, lay on the table, bang, like the old school chiropractor, quick, hard, high velocity manipulation. And listen, if you have a mechanical problem and people walked into chiropractor, crooked, snapped my back, I walked out straight. That's a mechanical problem, and they treated it. I have no problem with that. The problem is some chiropractors got themselves in a little bit of trouble because it's just a real aggressive approach really fast. And so that's why over the 25 years, they've toned it down a bit. It's funny, like now you see chiros doing heat and electricity, we're getting away from that. They're getting into that. So, it's like the two fields are kind of like trying to figure each other out. We're getting away. 25 years ago, we were just technicians, and now we're getting into more of this stuff. With chiros, because they were aggressive, they're backing their aggressive nature off, and they're getting into more like passive stuff too. So I have no problem with chiropractors, Joe. I have no problem with them.
Another thing I'd like to ask, in your place of work, you have a lot of good workers working there, and I've been there since 2002. You did a lot for me.
Yep.
And does any particular person specialize
Yeah.
in certain things in your office? Like
Yeah.
you refer to, say, Brian
Yep.
or another person
Yeah.
to say, what do you think of this or that? Because you feel that they're a little more, how would you say, tuned up on that particular part of the body
Yeah.
or anything like that?
Yeah, so remember I said in the beginning, I said, in 95, I started out here in a little closet, and it's bloomed into 11 offices, and I truly mean this. I just planted the seed, but really I was able to, connect with so many like-minded therapists. And so we are trained in mechanical diagnosis and therapy. We have 39 therapists in ProCare across the state. I think 20-something of us are certified in this, and it's like the black belt, So, yeah, in Flemington we have 5 black belts in this, essentially. So, look, if I'm struggling, I'm going to grab Alyssa or Brian, and I'm going to say, hey, could you help me out? Maybe I'm missing something here, But you're looking for someone who's certified in mechanical diagnosis and therapy. I don't know if that answers your question, but that's basically what we are. Yeah.
What are your thoughts on factor myth on different pillows or ways to sleep?
Yeah.
To avoid certain neck, shoulder, or back pain?
Yeah, that's a great question. I'm glad you brought that up, because I think my talk now, I can answer that. Like, I could answer that in a real common sense way. If your neck, if you're sitting slouching and protruding all day long, and then you lay on your back and you have a big pillow and your head's protruding all night long, you see there's no balance there, right? So we don't, so to answer your question, if we want to be, when we sleep, okay, trial and error. If you're not having problems sleeping, don't mess with it. Let's just start with that. But we tell people all the time, if I was a cardboard cutout and I picked that cardboard cutout up and laid it on its side, it might pay to fill some of these like voids. In other words, we have an hourglass figure. I don't, but we have an hourglass figure. So you put a pillow in that hollow, right? If your neck now, your shoulders on your side, you're sleeping on your side. If your pillow's too small, your head's like this. If your pillow's too big, your head's like this. Fill the hollow. You want to be neutral. It's the cardboard cutout concept. So people will say, I put a pillow between my knees, I got one under my hip, and I got one under my head. I'm like, perfect. It's perfect. So, if I had to answer that question, I'd use the cardboard cutout. But yeah, it's trial and error, and you got to play with it. And it's funny because the guy that shifted like this, we tell the guy, sleep on this side, not that side, because we don't want him waking up even more shifted, right? So you do sometimes use pillows to help treat these mechanical problems. They actually do positioning and pillows and whatnot. So, go ahead, Kyle.
Traction is something I've always been a fan of. What's your opinion on that?
Yeah. That's a good one, Kyle.
Joints in general, too.
Yeah, that's a good one. There's nothing wrong with traction. So basically all traction is if I took a string and pulled him this way and took a string and pulled him that way and just pulled his spine apart, it creates a little bit of a vacuum. It draws some of that stuff in, the jelly in. It's good. It's real good. So it can't hurt you. If you put 60 trillion pounds of traction through someone, I guess you could, kill them. But nonetheless, that's what those boards are. You see at Costco, you buy them, you flip yourself upside down. What are those things called? Inversion tables? It's traction, using gravity to pull you apart. But I have no issues with traction. It's a good method of treatment. In fact, we'll use it occasionally in necks in the office. Once in a while we'll use it. So we had some questions. We're going to answer some of these questions tonight. Mike, did I hit them all, or on the Facebook thing? Like, any other?
When would you say it's time to consider surgery?
Ooh, that's a good question. So, the time to, everyone. There are some people that are like, my back hurts. I'm tired of this. It's been a week. I'm having surgery. That's fine. You can have surgery whenever you want. But I think that the time to have surgery is when you have a problem that's hitting a nerve that's causing weakness that we can't reverse. And you don't want to wait too long. People come in and their foot's flopping. They got like a drop foot. And we're like, how long has that been like that? They're like, it's been 2 weeks. You're like, oh, yeah. You lay them down. We just start doing some things. We see them for a couple visits. And sometimes they get better. They start, oh, yeah, my foot feels better. And they come in, they're not flopping it. And we go, oh, good, let's hang in there. If we could get the pressure off the nerve and centralize, remember the centralization phenomenon, maybe some of the strength will come back. And we do get them better. Statistically, they're the hardest ones to get better. But that's the reason why you would have, it's not intense pain. It's more weakness in the extremity from the compressed nerve, because the worry is the nerve will be permanently damaged. and then you'll never get your strength back, and you'll be flopping your foot forever. Just like you had that surgery and you felt like $1 million, instantly he took the pressure off the nerve. And so so in a sense, you had to have that surgery. If no one could get the pressure off and you were getting weakness, you should have it. We tell people to have surgery in our office. We tell people to get, we're into all these treatments. It's just, what do you do? We like to think about like, we're the first line of defense, and then if this doesn't work, let's, break the glass and call the doctor, that sort of thing, the surgeon. What else we got on there? Yep.
I have a question. So I went to ProCare for a while. Now, do I need can I go
Yeah.
to ProCare and my insurance?
Yeah, that's a good.
will cover
I'm
it,
glad you
or
brought
I
that
need a
up.
doctor?
We're in network with every insurance.
My insurance covers.
Yeah,
it.
insurance covers. By law, you could come to us off the street. Yeah, you can. If your insurance requires, this or that, but you call us up, we'll tell you what to do. It's not hard. But by law, you could come in off the street now. You don't have to have a referral from a doctor. Yeah.
I got another question. With my spinal issue, with the pain, to stand or to walk any distance, severe pain.
Yeah.
One of my daughters came home borrowed from a friend, one of those walkers with your arms
Yeah.
up here.
Mm-hmm.
And I find I can go, I thought I was losing endurance, physical endurance.
Yeah.
Because by the time I got to a quarter of a mile, I had to sit down. I couldn't take it anymore, the numbness. By standing on that with my arms and walking, I can go for a mile and not.
Yeah. So you have severe lumbar stenosis, and so when you're flexed forward and you're taking weight off your spine, you feel better. So that thing is like leaning. You're just leaning. It's like leaning on the kitchen counter, but it has wheels. So now you're able to go. And then, so if that helps, then use it.
So if that helps to
Yeah.
to get me to do more distance, it's probably not a bad
Yeah.
thing, right?
The worry with
I feel
the worry with people like you is bending forward feels good, so you just start bending forward and forward and forward, and you start to get too tight. So now you start to lose, So we see patients like you, and we're like, all right, yeah, let's see if we can get you going a little bit in the other direction. We take little bites and see what we could do, But yeah, good. I'm glad you brought that up. Okay, Mike, what else do you have on there?
The only other one, what's more important, flexibility or strength?
Ooh, yeah, that's a good question. The answer is they're both very, very important. The most important thing, though, is range of motion. And the difference between range of motion and flexibility is this, because everyone's like, what? What's the range of motion and flexibility? Range of motion is the ability for your spine to move or your joint to move. Flexibility is your muscle and how much it extends, right? Your hamstring. Oh, my hamstring's tight. That's bad flexibility, muscle tightness. Range of motion is your ability for your joint to move. And look, if you have full range of motion in all directions, I guarantee you that disc is in the center. Guaranteed. So range of motion is the most important. Flexibility and strength are 1A, both equal. That's the answer to the question. Trick question. Yeah.
Would range of motion exercises be good then for the degenerative disc disorder?
Yeah, definitely. The thing with I just want to say this. We have so many people come in with degenerative disc disorder and get better. So I start saying to myself, wow, we're just regenerating people. We joke about it. I'm not quite sure how we get them better. We put them through our tests, we give them exercises, and we help them. Now, look, when I say get them better, I mean make them better, see improvements. They have to keep up, and so on and so forth. But yeah, I mean, if you stop moving, I think you said it, you feel your best when you're moving. I'll tell you right now, the people that come in, it's amazing. I mean, these people come in, they're like 98 years old. They're like, I don't stop. I was cutting the grass today. I'm just like, oh my God, it's 11 o'clock. I'm exhausted. The people that don't stop moving, those are the people that like live the longest and feel the best. So, I'm at this gym because I get lazy and I come here and we move in all directions and we strengthen in all directions. And I think it's good for me. And that's why I'm here. And then I met these guys, and they're like, you got to talk about back pain. And we're talking. So a healthy spine should be working out in a gym like this. A healthy spine. I mean, healthy. I mean, everything hurts. Everyone's. But if you have real big problems and you're crooked and your back hurts, you have pain down your leg, that's not the time to go lifting weights. Get better. Spend a month, get better, get back to the gym. That's what we tell people all the time.
What would be a testimony to the degenerative disc issue and then just getting educated by you guys?
Yeah.
And, my job is horrible. My head's always down. So coming to you guys and learning, like, the right ways to move and the right things to do. And, the left side of my neck would hurt and I stretched to the right so it felt better on the muscles. And you guys are like, no, don't do that. So you learn which ways to move,
Yeah.
how to take care of it. And I came to
Yeah.
a dozen years ago with the problem, and
I appreciate that. It's Dr. Lowe, orthodontist in Flemington. He'd been a ProCare patient for years, a good friend. Yeah, so you see the point he was saying. He's like, it hurt on my right, so I started stretching to the left. I mean, he just did what most people think they should do. And then we were like, stop doing that. You're making it worse. But it really hurts. I want to stretch it. And my mom always telling me, stretch it. It's like, your type of problem, we need to do this. 3 rotations, 5 side bends. And so we don't want to see people forever. We kind of educate them and how to manage it, maintain it, whatever it is. Some people, we get better. I mean, and forever. And I see them in ShopRite, and they're like, oh, my God, I haven't had a back problem in 10 years since I saw it. It's great. Other people, we really try and prevent the regression, slow the regression, or like Darren said, educate him so he could self-treat. And then when he gets in trouble, he calls us up. We're like, oh, here he is again. Yeah, exactly. Exactly. Yeah. So, I mean, if that's it. I don't know if Mike has anything to say, and Kyle, but I appreciate you having me out. Hope I answered everyone's question. I'll hang around. Like I said, if you call the office, I mean, we've got Alyssa, Brian, Jared runs our East Brunswick office. Like, these guys are better than me. And I'm not just saying that. I'm not just saying that. These guys are better than me. These guys are amazing therapists. My mother goes to Brian. I go to Alyssa. Yeah. And so when you call the office, don't ask for me. No, I'm just kidding. But yeah, I'll hang around, and if anyone has any questions, but thanks for having me, all right? Appreciate it. Thanks.